advanced procedures, including the brachytherapy and transperineal biopsy. And he is also a pioneer in the focal therapy using the irreversible electroporation or the nano knife with over 600 cases performed and significant contribute to the global research and clinical adoption of this technology. He also have more than 200 peer-reviewed publications, and today he will share his insights on the irreversible electroporation for the prostate cancer, why it should become a standard. Welcome, Professor.
Thank you so much for the honor of addressing you today. It's a great honor to speak to you in Thailand, and I'd very much like to share with you my experience in irreversible electroporation, which I commenced in 2013 and have now done just over 800 cases. Just before I start talking about irreversible electroporation, maybe just a brief introduction about focal therapy. As you know, focal therapy has become more popular, and focal therapy, as you can see by the pictures, can mean many things. What it means is that a section of the prostate is treated with a safety margin, and there are many energy sources which have been used. The reason why focal therapy has become popular is because we are better at seeing the lesion with MRI and PSMA, and we're better at biopsying as well. We know that it's been successful in other organs, and we also know that whole gland therapy, such as surgery and radiotherapy, are not without their side effects and have been shown to perhaps be over treatment in some cancers. Hash Ahmed, many years ago, showed that only a certain clone of cancers within the prostate spread. And if we can get rid of that, we may alter the natural history. And there's now 10-year data and early randomized controlled trials coming out. And naturally, as we all know, this is driven by patients. When we consult a patient, there are many things to talk about, but often the patient is more interested in quality of life than quantity of life. And this study that we did 14 years ago showed that, for example, patients are prepared to trade up to 28 months of living to avoid severe urinary leakage. So patients are prepared to trade quality of life for quantity of life. Recently, the Falcon Project was an international consensus of who is the right person for focal therapy. As I mentioned before, it's been shown that in very good randomized trials, such as the PROTECT trial, that there's very little danger to a patient with a Gleason 7 cancer. Indeed, even with 15 to 17 years of follow-up, there was almost no mortality, even in the active surveillance group. So we have a lot of what I call wriggle room or room to move in this area. And maybe this is the ideal group of people for focal therapy. Many surgical series have shown production of excellent surgery like robotic surgery. We're still seeing quite a lot of erectile dysfunction. And with radiotherapy, whilst we've managed to overcome a lot of the gastrointestinal side effects, we still suffer a lot of genitourinary side effects as supported by this study. And as I mentioned, the index lesion obviously is a strong philosophy or principle that guides focal therapy as well. So how many people might be suitable for focal therapy? Well, on this study, which is now 6 years old, Deepika Reddy thought that there may be up to 40% based on 3 randomized trials. So who are the candidates for partial ablation? The ideal person is a person who has a significant cancer, such as an ISUP2, and where it's focal, either localized or unilateral, thoroughly evaluated, visible on imaging, good co-registration, and who accepts relatively invasive monitoring and follow-up, but has a high utility for preserving genitourinary function and being aware of the uncertainty still with the lack of randomized trials. The ideal person is a Gleason grade 3 or Gleason grade 2, and maybe even 2 lesions which are close by. Even a solitary lesion crossing the midline, or a unilateral Gleason 2 tumor with no MRI lesion. I personally don't like treating anybody who hasn't got a definitive MRI lesion. More controversial is high-grade tumors, and more controversial is Gleason grade 1 with a clear MRI target. So why NanoKnife? I previously did a lot of HIFU before NanoKnife, and the reason why I like NanoKnife is because it was simple and safe, it was extremely reliable, and could treat anywhere in the prostate, the apex, around the urethra, anteriorly and posteriorly. We were very easily able to broaden the field, which has proven to be important. We have a good ablate resect study by Wilhelmine van den Bosch showing how successful it is. We get intraoperative feedback, which I'll show you. We've got good oncological outcomes with a very low in-field recurrence. It's applicable not only in the primary, but in the post-radiation setting. It's repeatable, and we can still do salvage surgery or radiotherapy. It's easily taught and learnt, and there are some unique aspects because it's not thermal, and it may even have an immune effect. It's well within our areas of expertise, and increasingly it's being accepted throughout the world, and currently 2 randomized trials are ongoing. So how does it work? It works by passing an electrical field at very high current, which causes holes, as you can see in the bottom section, in the cell membrane, which it cannot recover from. This is the setup. I've now done just over 800 cases since I commenced in 2013, where I was trained by Mark Emberton in England. It normally takes me between 45 to 60 minutes to do that. I'll just see if this works. This is a video just to explain the principle of how it works.
The NanoKnife system is the only function-preserving therapy that uses electricity to destroy prostate tumors. The procedure takes about an hour and has minimal recovery time. During the procedure, electrodes will be placed to bracket the targeted prostate tumor. The physician will use ultrasound to guide the placement of the electrodes. This therapy precisely targets the prostate tumor with electrical pulses that destroy cells.
So it's a very simple procedure, but it does require a certain amount of experience to place the electrodes appropriately to the image that you have. Just a quick run through of the history of NanoKnife or irreversible electroporation. In 2010, it was shown that prostate nerves in dogs were intact, and then it also showed that the urethra wasn't damaged. Then in 2016, the Resect-Ablate study confirmed complete ablation in the area of treatment in 16 patients who had their prostate removed 1 month later. Then phase 1 and 2 trials occurred, and then I was heavily involved in 5-year follow-up of patients with intermediate risk prostate, which prompted the National Institute of Clinical Excellence in 2023 to accept it, and it's now free in England through the NHS. In America then, the PRESERVE trial, which was the pivotal FDA trial, was performed, and that led to the FDA's approval for prostate ablation and AMA giving it a Category 1 classification. We know now that the next two things are large registries, and we currently have the largest in the world with greater than 1,000 patients, of which we intend to publish soon. And we also know that randomized controlled trials are pivotal, and the PRIS trial from Sweden and the PART trial from Oxford will be publishing in the next 2 years. So in terms of safety, this began in 2013, where Mark Emberton and I did some work to prove its safety. In terms of limitations, there virtually are none. Extreme apex, posterolateral, next to the urethra, next to calcification, which of course is a exclusion criteria for HIFU. In the anterior prostate, another exclusion criteria for HIFU, or even a broad capsular front, as we can treat extracapsular disease. One of its unique advantages is the ability to preserve tubular structures. Indeed, irreversible electroporation started in the liver in metastases close to critical structures. And so the urethra and the nerves appear to be better preserved by this technology than by thermal energy. This was Wilhelmine van den Boss's study, showing that in the Ablate Resect study of 16 patients, there was no viable cells in the ablated area, and the margin from viable to non-viable was less than 1 millimeter. So if this is the urethra and there's a lesion here anterior to the urethra, we have to place electrodes correctly. And so if we placed electrodes like this, then one electrode here next to the urethra would create heat, as there's heat within 2 to 3 millimeters of the urethra. So that is incorrect. So the correct way to do this, to still treat around the urethra, but to ensure no damage to the urethra, is to place the electrodes more than 3 millimeters away. Now, I mentioned before that if you've got a lesion like an MRI lesion and you want to have a safety margin, you do need to have at least a 1 centimeter safety margin. And one of the nice things about electroporation is that if you have 4 electrodes, such as on the right side of the picture, the ablation is much larger. And so it automatically forces you to give a much bigger ablation margin, because it's been shown that the MRI underestimates the extent of the cancer for up to 9 to 10 millimeters. And the other thing is, does it really improve the chance of erection nerves recovering? Well, this randomized controlled trial reported 3 years ago showed that if you have focal versus extended IRE and randomize it, then initially at the less than 6-month mark, there was quite a significant difference of erectile functioning, but greater than 6 months, there was no significant difference, suggesting that even with more extensive ablation, there's a recovery of erectile functioning. And here, for example, on the left, you've got a lesion, and here's the placement of the electrodes. And those electrodes will then cause this ablation zone, which will give you a very good safety margin. While you're doing the treatment, it's important to make sure that the amperage is above 15 amps, as if it's below 15 amps, you'll get reversible electroporation and you won't kill the cancer. During the procedure, one of the advantages of this is that as you're treating it, so here's the 5 electrodes, as you're treating it, everything goes white in the treated zone from hydrolysis. That gives you a feedback that you're actually in the right place, and you can use the longitudinal or axial scan. Here at the bottom, you'll see that there's a black area which is surrounded by white in the middle of a treatment. And cancers tend to stay black because they're denser and they don't allow hydrolysis. Again, another nice feedback while you're doing the procedure. One of the questions we asked was, if we treat the extreme apex or the anterior zone or the posterior zone, would the quality of life be the same? And in this study done by Matt Sheltimer, we show that was the case. Even the extreme apex, which many technologies avoid, is suitable for this technology as it preserves the sphincter as it's a structure. And in the 50 patients in this study, we found that the incontinence rate and the in-field clearance was the same as our general group. And just recently, we've been working on trying to prove that we can treat micro extracapsular disease. And on the left-hand side of the diagram this is a radical prostatectomy after failed nanoknife therapy. But what was interesting is where the nanoknife was done on the left-hand side, and there was extracapsular disease at the original pathology, there was no recurrence in the nanoknife area. The recurrence was on the other side of the prostate or at the apex. So we're working to try and prove that we can treat minimal extracapsular disease, but that's not published yet. Post-operatively, everybody gets 3 monthly PSAs. The MRI is done at 6 months, but we do an initial one at 2 days just for quality control. And we do quality of life EPIC questionnaires every 6 months. And we recommend a biopsy at 1 year, but only 80% of people agree. As if they see the PSA is low and the MRI is clear, they prefer to avoid it. The PSA is very unreliable. Here's an example of many patients at the 6-month mark where some of the PSAs were actually higher and some were lower. And as you can see, you can't rely heavily on the early PSAs. Here is the 2-day MRI. And for example, if we had a lesion here, here's the MRI lesion here. And if we had a lesion here, here's the 2-day post-gadolinium T1 picture that shows good clearance. It's a very reassuring thing to do it at the 2-day mark. This is our first publication, which was 5-year data. And it showed that if we included all the patients that we treated, including the first 20 where we only had a 5mm safety margin, our in-field recurrence rate was 9.7%, whilst if we treated with a wide safety margin, we got it down to 2.7%, which was an incredibly low in-field positive margin rate compared to other technologies. And this was another paper we published in 2023 in 530 patients, 244 of which had had at least an 18-month follow-up. And we treated all areas, lesions, quadrants, hemiablation, apex, anterior. And obviously, there were a few Gleason 3+3s, even a few 4+4s. But what we found here, and the critical number here, is the 84% failure-free survival, avoiding surgery or radiotherapy. And we were wondering recently whether, if we updated that to the current time, including all the patients up to 2025, would this failure-free survival continue? And we have shown that, but this is unpublished data. So the failure-free survival is between 80 and 85%. And that's with a 7-year median follow-up. What about side effects? The incontinence rate is very low. In fact, virtually none of our patients have been incontinent. Erectile functioning is about 10% initially, falling down to 5% at 1 year, and we've had no major side effects and no fistulae. And the next question, of course, is, are these repeatable? Well, John Yaxley, with smaller numbers here, showed that his infield, his clear on biopsy rate and continence rate were very, very similar to ours, except he had smaller numbers. Recently, the pivotal PRESERVE trial in America showed exactly the same data as ours, and the infield positive biopsy rate for them, and all of these people were in their learning curve, was 84%. But I think that this definition included Gleason 6 tumors, but if you include Gleason 7, the infield recurrence, of course, is much lower. I've trained many, many units around Australia, and they've equally duplicated the data. In the world now, there's over 540 facilities that use this. And if you have to do a radical prostatectomy afterwards, the results, as you can see here, a 91% negative margin rate and minimal incontinence, mimic a primary series, not a salvage series. And this was also, I'll pass this slide, it's complicated. The next question is, can you repeat it? And the answer is yes, you can. Let's say you get another lesion in the other side of the prostate, then could you ablate that? And the answer is yes, but your failure-free survival goes down to about 64%. We're working with the Focal Therapy Society to try and work out whether we can treat high-grade disease. And I thought I'd share this slide with you. And what it shows, if you have a look carefully, is that 30% of patients required salvage treatment locally. So the failure-free survival with high-grade disease is higher. And then there's been a lot of systematic reviews echoing exactly what we're saying. High pad-free rate, infield recurrence did vary between 0 and 30%. Oh, sorry, 0 and 33%, overall 8%. And Thai showed that in HIFU, cryo, and IRE, the results are actually quite similar, but naturally with HIFU, there's a patient selection going on. And then there's multiple different energy sources around, as you know. And this nice study by Hopstarken showed that NanoKnife performed very well with a low side effect profile and a very low infield recurrence rate. However, a 2025 paper showed that the cancer-specific survival, relapse-free survival, was similar between all energies, and the side effect profile was very similar. My concerns about other energies have been HIFU. It's a challenge with the prostate size and calcification in the extreme apex. With lasers, the extreme apex and extracapsular disease are difficult. It's often in bore. Cryotherapy, the extreme apex is difficult and you get urethral sparing. Brachytherapy has been trialled in Australia. It's not repeatable. It's unknown effect on the treatment zone. And TULSA is the hottest thing around at the moment. It's very time consuming. It's in bore. Calcification is still a problem, and you get urethral heating. So the randomized trials, of course, are the PART trial and the PRIS trial. The PRIS trial is about to publish its initial data this year. We now have over 1,000 patients in our registry. And I'm going to, for the interest of time, pass over the salvage data and really come then to the conclusions. So primary IRE, both primary and salvage, is safe and is suitable in men with unilateral localized intermediate risk prostate cancer. Strict follow-up's essential. IRE provides a reliable in-field ablation and acceptable medium-term oncological and functional outcomes. It's simple and quick. It's applicable to every area. It's unique in that it's not thermal, and patient selection and targeting does need to improve, and PSMA PET scanning may help that. And obviously, the randomized trials we look forward to seeing. We've even published some work to show that nanoknife may create a vaccine effect, and we're working with the immunologist to see if we can combine that with a checkpoint inhibitor. So it's much more accepted in the world these days. The NHS is accepted, the FDA is accepted. We're working with Medicare, but the guidelines are awaiting randomized trials. So in conclusion, I thank you so much for your attention. I always look to Mahatma Gandhi for inspiration, and he introduced many new things. And as he said, first they ignore you, then they laugh at you, then they fight you, and then you win. So I thank you very much for your attention, and look forward to any questions.
Thank you very much, Professor Stricker, for the great talk and excellent work. We also have the more than 100 Thai urology community here. Is there any question from the floor? In the meantime, I have few questions to ask. For my standpoint, I'm quite a big fan from your work, but I also have some issue about the extreme apical lesion, especially on the posterior side. Is there any recommendation from you to handle with this case like this?
I've been really impressed with the extreme apex. In fact, you can even treat 2 or 3 millimeters beyond the extreme apex and be confident that you're not going to lead to incontinence. And I think that's quite unique to irreversible electroporation, because I know that my colleagues who do HIFU or cryo or even TULSA say that they're particularly concerned about a thermal therapy at that point. And in Alex Blazevsky's paper on 50 patients prospectively collected, that was borne out to be correct. But there are techniques to doing it. You have to place the electrodes, the active tip 3 millimeters from the extreme apex. And as you know, the apex curves. So you need to check in the longitudinal axis to make sure that they're all in the correct position.
You mentioned about the salvage IRE. How this compare the result to the whole gland treatment? in term different setting about the infield or outfield, which one is a better response?
So the Tulsa data is very young. The TACT trial of Tulsa is the longest data. It's 5 years. And that was done through many centers, and it was their beginning, their learning curve. And the initial biopsy suggests that there was an 20% infield recurrence, which was way too high. Now, I've spoken with Professor Laurie Klotz about this, and he says the technique has improved considerably, but the follow-up is still short. Just recently at the EAU, they presented the initial quality of life data, but not the oncological data for the CAPTAIN trial, which is the randomized trial. And that the randomized trial will be publishing at the end of this year. And I think that will be very interesting to see, because all the patients in the CAPTAIN trial got a biopsy of the outer edge after Tulsa. So I think it's too early to tell.
Because we are run out of time. Thank you very much, Professor Stricker.
Yeah, hope to see you in Thailand, maybe in the future.
I look forward to coming, and thanks for the honor of presenting.
Okay, thank you. So we would like to close this session. Thank you very much, Professor.
Thank you.
น้อง Resident ที่จะมาแข่ง Resident Contest ให้มานั่งแถวหน้านะคะทั้ง13ทีมเลยค่ะ
Recording stopped.
Jolene?
Hi, thanks so much. Thanks so much, Dr. Shekhar.
Did that
I'm not sure why my video cannot turn.
Were you happy with that?
Yes. Yes, I think it's very good overview for them. It's
Okay,
very good. I
fantastic.
also still have some pictures. I'm going to send it to you. Yeah.
Yes.
Thanks a
Thank
lot.
you, Professor
Very
Stricker.
clear, super clear.
Thank you
I love
so
your
much.
presentation.
Thank you.
Thanks
Okay.
a lot.
All
Thank
the
you.
best.
Bye.
Thank you.
Cheers. Bye.
See you. Bye.
Bye-bye.
Bye.
Thank you. Bye-bye.